Good afternoon, everyone. Firstly, thank you very much for attending the Intuitive Lunchbox session. My name's Dan Musker. I'm the marketing leader at Intuitive in the UK. It's a great pleasure to welcome Mr. Tom Routledge from Guy's St Thomas's Hospital and also Mr. Rocco Valencia from Golden Jubilee in Glasgow. And they're going to be talking about the Vinci lobectomy from initial training through to productivity. So just conscious of time, I shall now hand over and we'll get stuck into the session. So okay, over to you.
Sorry, Dan. How does it load? Oh, should be coming. Right. I'll go back. So good afternoon, everyone. Hope you can hear me well. So I'm going to be talking today about our early experience with our robotic program. I'm one of the consultant surgeons in Glasgow. A disclosure to make, I'm a proctor and a speaker for Intuitive, but more importantly, I am a RATS enthusiast, so of course my talk is going to be biased heavily by that one. My background, I've been working at Golden Jubilee since 2017, formally completed training in Italy, then moved to the UK for further training, and at the end of my training, when I started as a consultant, I was fully VATS and open trained. A bit of background about the Golden Jubilee. We're based in Glasgow, Scotland. We have quite a large catchment area. We're certainly one of the largest thoracic surgery units in Britain and Ireland with a number, 11 lung cancer MDTs. We, at the time when I started, we were 5.5 full-time surgeons performing about 1,400 thoracic surgery operation a year, and about 500 lung cancer resection per year. We used to have, they used to have already a quite high VATS rate at the time with good resection rates. When they first started talking about the possibility of robotic surgery at the Jubilee was 2015. I was not yet there. They went on to do a cadaver course in February 2016, and then a first visit to Pisa, a demo day at the Golden Jubilee, and then we started making, talks obviously with our management until we initiated a short-lived working group for business case. And then at the beginning of 2018, we had final board approval, and on Good Friday 2018, the Da Vinci was actually delivered. This was a business model for an ex Da Vinci for thoracic use only. And the first case was then performed in May 2018. The model of adoption that we used, we had the first two more senior consultants initiating the program at the beginning. So it was a kind of two consultant scrub type of cases at the beginning. And then we evolved, once they were fully trained, we evolved into getting surgeon 3, surgeon 4, which was me, up to surgeon 7. At this time, surgeon 2 has now retired, and surgeon 7 is actually the first, in-house RATS-trained NTN. The idea was to have, one surgeon trained at a time, but the whole team together. So there was quite a lot of support in terms of getting cases and good case selection right from the beginning. Quite interesting, we are and we were a quite diverse group in terms of age and previous experience. And in terms of institutional learning curve, it's for these reasons you had through time individuals at very different stages of their learning curve. At this moment, we have an X, which is the original one we have, and an XI for multi-specialty use as well, for basically 6 full-day robotic sessions per week. So essentially 1 robotic list and 1 non-robotic list for each consultant. It was important at the beginning to get the whole team trained. Obviously, it's not just about the surgeon being able to operate on a console. It's about the team going together. In particular, the need for first assistance. We started off with nurses who were able to act or learn to be first assistants. Then we had surgical first assistance trainees. That now we actually lost to colorectal surgery, and what we are actually, which is a developing program in our hospital at the moment, and what we replaced those with is a much larger number of core trainees that actually are quite happy to have in their portfolio the ability to do the online modules, the formal training as a first assistant, and then actually assisting in robotic cases. Some of them, of course, will have an interest in specialties that do require some form of robotic training at some point. Of course, scrub nurses, the anesthetic team, were heavily involved in making sure we did everything safely and everything was thoroughly thought at inception. We had a concern about the ability to train our own NTNs. Of course, they were getting quite a lot of training when we were a VATS unit, and now evolving into RATS. Of course, we know, it's probably a shared experience at the beginning. There is some suffering on that side, but obviously, and a good example is our senior trainee becoming a trained robotic consultant. This is no longer an issue. And in fact, we have more training cases that we are actually then trainees to train. In terms of patient safety, we came together as a team. The anesthetists put together a kind of a RATS guidance manual to make everyone feel comfortable with robotic surgery. We established a dedicated robotic pause on top of the WHO pause, where we also outline clear roles for each person in the room, especially in case of emergencies. So for example, for bleeding or anesthetic emergencies, indeed. And we make that robotic pause as part of our WHO pause. We also have a robotic friend, a robotic buddy, so another consultant who's usually operating next door or somewhere in the hospital available if there's any need for a second opinion or any emergency. It's probably become redundant as a practice, but we kind of kept this as a kind of contributed to creating that nice team environment where we often have interactions, amongst ourselves with regard to specific cases. We did and we continue to do emergency drills and simulation of scenarios on our CME days, and this is to make sure all staff remain familiar with the emergency protocols, and the new staff are also trained on that as well. Immediately, we had some intangible improvements, which is obviously team building and enthusiasm. People have touched on this before. We feel it's increased our staff skills at every level, and that's actually generating momentum and enthusiasm within the team to make more progressive improvements throughout the organization, whether that is for cost efficiency or for ERAS. We think it also increased possibly our visibility and our international reputation, and it served to us as a model for introducing novelties safely. So why RATS? Obviously, I'm not going to stay too much on this, but we feel it's better for the surgeon. We've said this before. My personal highlights is that, of course, you've got a total thoracoscopic approach with CO2. The exposure is absolutely magnificent. You have a 10 times magnification, so the structures are really close to you, and with the console experience, it's really a 3D immersive view that you are experiencing. The camera is also operating by the surgeon, which is not the case by VATS, obviously, and depending on the skills of your assistant, they can be quite painful at times. I think the ergonomics, the fact that you're sitting and you have the possibility to pause at any time for a cup of water while they're exchanging instruments, I think this makes the experience much more relaxed for the surgeon, and that has I think an impact on the final outcomes in that you are certainly able, I'm personally certainly able to, as I have less discomfort, I'm less tired or less frustrated, I'm more concentrated, and I'm more able therefore, I think, to perform more complex maneuvers, possibly for a longer period of time. The technology is probably the best that you can get at the present moment. The EndoWrist technology, which also applies to staplers, allows you to go around structures and use very precise movements for tissue handling. Probably less pain for the patient because of the balance instrument moving around the remote centers, and you have a full range of instruments repertoire and integrated technology. What we wanted to achieve was obviously the typical advantages of minimal invasive surgery: less blood loss, less pain, less morbidity, quicker recovery. Like we were saying, some units, probably not as much in ours, perhaps because of the Glasgow population, perhaps because of us. I think we had some improvements that could be made in that. But as we started robotic surgery, we also realized there might be other advantages, in particular, as Tom was highlighting before, with the ability to perform a better lymphadenectomy or more complex cases by minimal invasive surgery. We think we have better oncological clearance and therefore better staging as well, and therefore, because of a quicker recovery and increased chemo uptake in our patients. The performance results enhanced from all points of view. I have a curve to show about how our conversion rate had actually gone down significantly from the beginning. Once you get past your learning curve, we feel we have less air leak, which is the number one problem, obviously, to get patients home in due course. We were talking about lymphadenectomy before. We were able to increase our number of minimal invasive segmentectomies, the sleeve resections, and the ability to do more advanced tumor or more difficult anatomy patients. So patients, for example, with a very large body habitus. We managed with all this to also increase our resection rates. We were probably hovering in our across the different health boards around about 20% when we started. We are very close to 30% at the moment. So it's a massive advantage, especially for a sick population as the Central Belt Scotland population. In the current landscape, the ability to do all this, where there is a drive for more segmentectomies, lung cancer screening is coming, and neoadjuvant therapies are also on the increase. The ability to do more complex things or target things with segmentectomies with a minimal invasive approach is obviously quite appealing. And that is the other appeal of the robotic technology, is that it is also an evolving technology. And probably, if we compare what we see now with what we were used to see just a few years ago and what we could be seeing in the future, of course, probably there's a lot more to come in the future that might actually even more enhance our performance. We feel it's better for training. I was saying at the beginning, obviously, you're trying to get the good case selection and therefore maybe the simpler cases to be done under the robot. You want the results. You want to show the results to your managers. And that obviously influences your ability to do more complex things at the beginning. And therefore, all those simpler things are taken away from the hands of the trainee. However, overall, as a package, we think there is a lot more to gain for the adjunct tools that you have with robotic surgery. First, for obviously consultants who are starting the training program, there is a very well-structured pathway. I'm going to talk about this in a second. The quality of the simulation that you can do, the virtual simulation that you can do, is also very high. You have the ability, if you have a trainee with you, to actually write on the touchscreen monitor and therefore actually show to the surgeon what you want things to be cut, or if you want to highlight vessels or anatomy. You can write any sorts of message, obviously, on the screen as well. And you have obviously the dual console, which is which makes it quite safe to accompany the trainee throughout the case. And then there's a number of self-learning adjuncts as well, such as the My Intuitive app that I'm going to talk to you about. The prime pathway, obviously, you start off with pre-clinical training while you're basically learning how to drive the car. Okay, you want to make sure you're safe at doing so, and then as you're pushing this forward, you start doing some obviously simulations and wet labs on, it used to be on cadavers, it is now on heart and lung model essentially, and then you start off with your very simple cases, so wedge resections, lymph node dissections. Pneumothorax is actually quite a good operation because of your ability to do a pleurectomy, if you're used to do pleurectomy, obviously, for learning the dexterity. And then as you proceed in your further training, you go on to do more, your first lobectomies and your more complex ones. And that's just an overview of basically what I've just said. There's a proctor that accompanies you in your first simple cases and then your first lobectomies. And of course, you have an evaluation form. You're evaluated for a number of skills that you need to acquire to be deemed fit or safe to carry on your own. The practical steps that I personally made, of course, the preliminary ones was to complete the online modules, the test drive with an intuitive rep to make sure we were comfortable with, the docking procedure, the functioning of the machine, and then you do your 40-hour simulation at the console. You go for a case observation visit, the surgeon, but also people from your team, and then, like I said, you go on to do hands-on wet lab where your skills are also assessed and your first non-lobectomy cases, and then as you refine your training on a wet lab with advanced technology as well in the mix, you then start to do your first lobectomies. Training tools, the sim now is the simulator that we use. Of course, there's, as you can see on the left, there's a number of kind of skills that you can acquire with specific exercise. You can see, for example, wrist articulation, pick and place, bimanual transfer, and there's a number of exercises linked to each of these skills that you are wanting to acquire or refine. It's simple exercises, such as, for example, the C-spikes. So you put in, you're moving things on the C-spikes, or some basic suturing, linear suturing. But there is also some procedure simulation, which is, I think, compared to other simulation tools that I have seen, it is relatively realistic, and especially I think the most that you could get by procedure simulation is actually your ability to retract. So I think the threshold for giving you bleeding or a lung tear is very low for that simulation. I think that really helps you try and figure out how to best retract or moderate or temperate your movements to avoid lung injuries. And then, of course, you get a scoring for each of the exercises, and it's all very detailed in your certificates, how many times you've attempted, how long it's taken you, how long you've actually needed to practice on that. So it kind of helps you also identify which areas of your skills you need to refine further, and therefore what exercises to concentrate on. You can also do dry lab simulation with a plastic chest or abdomen, where obviously you do have 3D actual rubber C-spikes. You could learn how to suture a banana or peel off a banana. But I think the dry lab simulation remains one of the kind of simulation tools that I actually use. And for example, when we performed our first robotic sleeve in the days ahead of the procedure, we actually simulated at dividing and putting together the two ends of a chest drain. And the picture on the right is not very clear, but I hope you can see the suture line, which was quite satisfying. And in preparation for an operation that we'd never done before, we thought that was really useful. When you go onto your training, TR200 to TR300 training, the model that's actually used, like I was saying, is a heart and lung model. I'm not going to spend too much time on this. There's a very nice video from Joel Dunning, I don't know if Joel's in the room, that explains very well how you can make the most out of that model. And then you've got the My Intuitive app, where you can actually monitor your own performance and see how many cases, what kind of case mix you've actually been doing. And your procedure trends. I think this curve explains quite well what the most common trajectory is. As you see, there was a lot of time spent at the beginning for a lobectomy. Obviously, you get in the team also comfortable with the procedure in the new operative environment, and then your operating times would go down and hover around an average until, as you can see, in your after your 100th case, probably for most of us, the numbers will start going down quite significantly. The app will also tell you, it's accessible on a web browser, so it will also tell you what instruments you are using the most, so that you can also make efficiencies in your cost efficiencies, of course. And you will have a case history where you can pick with all your cases, and you can pick for each case, you will know how long it's taken you to do the case, the consult time, what staplers you've used, how many instruments changes are you changing instruments to frequently, or are you actually quite, you have good exposure, you're actually managing with fewer changes. You also have, and this is quite, I think, useful when you're using dual consult with your trainee. It gives you a timeline as well for each case, where you can actually see what you've been doing, what the trainee has been doing. So you can see consult 2 in this case is the trained surgeon. So our trainee, and you can see they started off with doing basically most of the case. Then I took over a couple of times for a couple of critical adjustments, and then at the end of the case, I did the lymphadenectomy. So that's the rest of the curve. Because one, it's quite enjoyable, and just to speed things up to get the other case done after. So it's quite useful adjunct in the app as well as on the web browser. Then you also have some videos that are kind of technology training, so that can actually help you, especially at the beginning, with the troubleshooting of any problems you may encounter with the actual robot. At the moment, we've done about 1,200 robotic operations so far. In majority, it's lobectomies. Segmentectomies are on the rise. We've started coupling, in monitoring our performance, lobectomy and segmentectomy together. As you can see, we are currently doing consistently more RATS operation than VATS operation. It's about 2/3 and 1/3. We're doing VATS operation mainly for unavailability of the robot. Once we all started, there was never a way back. Nobody really wanted to go back. This is a slide I was telling you about conversion rate. So on the left is the number of operations, cumulative number of operations, and on the right is the percentage of conversion. Of course, it was quite high when we started with the first cases, and now it's kind of hovering between 2% and 3%, so it's very low. Certainly probably half or even less compared to what we used to have with VATS. There was a crucial moment in our institution when we reached about 350 robotic operations, where the lines started to cross. And at about that time, I had performed about 100 robotic cases. At that point, I had 3 conversions to open that were all elective for controlled bleeding or calcified nodes, and I also had 3 conversions to VATS. Now, I wanted to focus on this time of my learning curve because, as you can see, we were showing some results to the managers. So, for example, you can see this is the cumulative length of stay for patients according to approach, and you can see that if you draw the 50% line, you could see that 50% of the patients were going home in 4 days for RATS, 5 days for VATS, 6 days for open, so there was a saving in terms of length of stay. And if you raise the bar to 90%, you could see that the ones that were staying in hospital the longer, so 90% of the patients went home at 6.5 days for RATS, but was 11.5 days for both VATS and open. So also the patients staying long-term with much more serious complications were also a lot more for open and VATS. Operating times, this is again at that kind of time screenshot in my learning curve. You could see that after some adjustment for docking time, there wasn't much difference with VATS. And obviously, we were able to provide some data. I know Tom is going to show a lot more about this, so I'm not going to spend too much time here. My learning curve, I want to show this picture. It kind of stops at that 100 case here. And the reason is because I wanted to highlight what happened in the early, mid, and late learning curve. And the early learning curve, you can see there's a spike. I'm going up. I'm getting very excited about this new thing, and then it goes down. When you start encountering frustration, you started with minor cases. The first lobectomies, you're starting to do upper lobes regularly, which were considered a few years ago at least kind of a second level operational lobectomy. Then you start to try to do 2 major cases every day. Had good case selection at that time, and at the time when I had that drop, I had also conversions to VATS, try and go back to my comfort zone. I never went back to RATS. I never had any other conversions to VATS any time in my later experience. So it's really kind of a measure of frustration that can happen in this phase. And the key to this phase, I think, is to maintain continuity. Then in the mid learning curve, trying to keep continuity, comfortable with simple cases, you're becoming quicker, you try different setups. So I started, for example, not using or tried deliberately not to use the 4th arm, although for safety I still had it, ready for compression if there was anything. any problems, and I was effectively doing a three-port approach with the utility port. And then I realized the utility port was the problem. Lots of patients were coming back to clinic and the pain was more localized in the only non-robotic port. So I got rid of that, and at the moment my setup is to do 4 robotic-only port procedures. So you start to explore this as this time, and you can see that once you've reached that kind of productivity zone, you kind of hover. And then it goes back up as you're able to do more complex cases, for example, incomplete fissures, patients with lymphadenopathies, fibrotic lung, you start doing more segmentectomies as well. And at that point, I also had an increase, for example, in conversions to open. Again, I think it's a healthy reflection that I'm not focusing on the simpler cases only, but I'm also trying to push a little bit farther. And until at the end of that kind of period, we also performed our first bronchial sleeve lobectomy. So in conclusion, I think the key thing is the team, growing together, not only, with your colleague surgeon, but with the rest of the staff, the anesthetist, to have a stepwise approach, so be patient and do the right steps at the right time. Simulated practice, I think it's quite a keystone, including dry labs that, you can continue to do as you are evolving in your experience. It is important that you are not too impatient. You learn to be comfortable and drive the machine first before you start to do more complex stuff, or otherwise you won't have good data to show to your managers. The other key advice is to be regular. So at the beginning, when at some point COVID hit as well, so I was trying to rather do maybe 1 case every time rather than try to do 2 cases, not doing anything and not do any of them well enough, but try to be regular when you only have a small amount of cases that you can access. And I also advise to keep a standardized approach and only modify it to your preference as you go along. As I showed, you also have tools to review your performance and learn from it, and so I also warmly advise to do it. And that's a picture of the team Glasgow. Thank you.
Hi everybody, can we change the slides over, thanks. Who in the room is currently personally involved in the wonderful business of robotic thoracic surgery? And who would like to do more? And I think that's what I want to talk to you a little bit about today. We're at a situation now where this is not something that's totally new, that people need educating about what it's all about and how to do it and what the advantages might be. This is a situation as to how we move from what are really a community of pilot programs to a mature service. And actually, it's probably more difficult than going from 0 to a pilot program, which we know the majority of UK units have already done. And I want to talk to you a little bit about how to be big in terms of your overall case volumes, how to be fast in terms of your operating room efficiency, and how to train the youth. Because there's no point in doing all of this if you torpedo your training. And that has definitely been a problem with early robotic programs, is that they've been entirely consultant delivered, and you've taken those easy stage 1 lobectomies away from being a registrar case to being a consultant case done at half speed. And that's okay for a bit, but we need to be very careful to restore the balance in training. And I'm going to talk to you a little bit about pipeline technologies. So just as a very brief introduction, I'm from Guy's. We started about 2017 with just me doing a list every 2 weeks, stolen from the urologists. We had a registrar bedside assist. My eternal thanks to Miss Elsa Haff for providing this service with various degrees of good and bad temper. I was kind of largely self-taught, which led to lots of technical dead ends and a slightly haphazard learning curve. And now where are we in 2024? We have 7 or 8 robotic days a week, which means we have dual robotic days quite a lot of the time in adjacent operating rooms. This does lead to a degree of registrars racing each other, which is to be encouraged. We are running 3, sometimes even 4 case days. We have thoracic hit lists coming to try and cope with the fact that we're a small city centre site hospital, and so we can't build more operating teams. So we are trying to find ways to make our already efficient lists ever more efficient. We have, I think, 5 robotic surgeons on service. We have a stabilized shared technique. You'll hear a lot about the advantage of protocolizing things, and we try to protocolize technique to an extent across different surgeons. We're doing a lot. We think we're probably going to do 700 or 800 major lung resections this year. We've obviously done multiple thousands to get to this point. I'm now at a point, I do 2 days operating a week. 95% of my major resections or more are completed robotically. We do pneumonectomies, we've done vascular sleeves, we're starting to do post-immunotherapy, post-TB. So there's very little that we don't do robotically in terms of major resections. And we're probably at a point where I think about 30% of our cases are being done with the registrar as the primary operator, which is not where we should be, but is heading in the right direction. As a team, I think the problem the UK thoracic community has at the moment is we're mostly stuck in a pilot phase. So everyone's very pleased that they've started robotics, but it's still a little bit of a sideshow compared to their main event VATs that they do most of their cases. And the question is how we as a community can move from doing a little bit every other Wednesday afternoon to this being just how we do surgery, which I think is where we should be. And how would I advise people on how to achieve this? Well, first of all, be upfront about what you need. Work out how many cases you should be doing robotically. Build in the growth that you'll see from screening, the growth that you'll see from the Checkmate study, meaning that cases that weren't surgical now become surgical, although they take a little bit longer. Work out how many days a week of robotic access you require as a team to do what you aspire to do, and ask for that. Be upfront about that's what you need to run the service that you should be running for the benefit of your patients. Don't settle for, oh, can we have an extra half a day every other week? Maybe, thank you very much, sir. Say, no, this is what we need, put evidence behind it, and make a big request. Aspire to train all of your surgeons. This is not an aspiration we've met yet, but we're nearly there, Mr. Pilling. And have a plan for your bedside assistants. So this is very much not all about the guy on the console. You will need to have an excellent bedside assistant team if you're going to grow and become efficient, and if you're going to train. Don't use registrars, because registrars come and go, and they should be on the console. Don't use consultant colleagues, because if we turn this as a community from a 1 consultant into a 2 consultant operation, that's a terrible retrograde step. You're going to have to use some form of surgical first assist or SCP. This is obviously the middle of a rather traumatic national debate about advanced roles and where things should lie. And I know there are variations in practice across the UK at the moment, and I suspect we'll see more governance and more guidelines emerging soon. But clearly some form of advanced nursing role as at the bedside is the right solution if you are serious about having a mature service rather than an ad hoc pilot. And collect your data, your clinical data and your financial data, and publish it, even if it's a little bit baloney. Maybe think about playing the system a little bit. Work out which groups of your patients you think should be done robotically. Maybe it's segmentectomies, maybe it's everybody. And say to your managers, we need to do these patients robotically. If we can't do them robotically with our current access, then we'll see a 6 or 8 or 10 week waiting list, or we'll refer them up the road, or whatever you need to do. But none of us want to use patients as pawns, but there comes to a point where you need to stick to your guns if you really believe that you are underserving your patients by doing them VATs simply because your hospital is too slow to improve your robotic access. And we should stick to our guns if we really think it's better for a particular cohort and say, we are only going to do these patients robotically. You need to provide us with the wherewithal to do that. List efficiency. So this is an ongoing problem across Europe, not just in the UK. There is a perception that robotics is slower. There's a perception that you can only do 2 cases in a day. And that's a problem, seeing as we're all groaning under the burden of screening and ever-increasing surgical volumes and the difficulties in expanding our operating room access. We need to find ways to do 3 robotic cases in a day as a norm for most operating rooms. And there is no secret sauce to this. Definitely it starts with the surgical console time, or rather the surgical time. And people tend to focus, understandably, on the console time because that's what's measured, that's what everybody shares data on and publishes data on. But actually, I think your console times will come down naturally, as Rocco's just shown you. But actually, if you want to make your overall operating room time shorter, I think focusing on what happens before and particularly after the console time is most important. Yes, you can save 5 or 10 minutes by docking more quickly, but when I watch teams at the mid part of their learning curve doing this, they'll do a very nice, efficient job docking, and they'll do a reasonably nice job on the console. And then as soon as you've finished, you've taken out the last lymph node, you've fired the last staple load, the kind of focus levels in the entire room drops massively, and people will then faff around for another 45 minutes, doing things that could be done in 5 or 10 minutes. And so if you want to find out where to make your overall operative times more quick, focus on the console time, on the post-console times. Watch your videos. Mostly you'll be horrified by how much loss of focus leads to an enormous amount of just faffing about at this time. I think most teams could save half an hour in each operation very simply by just making this part of the operation more quick. And some of that will involve surgical leadership, and some of it involves just maintaining your focus just because the robot isn't docked anymore. Obviously, turnaround times are difficult and are very institution dependent. I think you can make a reasonable case wherever you are and however catastrophic your anesthetic and turnaround times are by saying we should hire extra staff to make it quicker, even if it's a short-term solution. Robotic days are very precious commodities in most trusts, and if you can make things quicker by doing a kind of semi-hit list, by hiring an extra ODP or an extra scrub nurse or whatever you need to reduce your turnaround times, then that's money well spent. It's a lot cheaper to hire an ODP for a couple of lists a week than to buy a new robot to try and get more cases done. So look at where the pinch points are and think about extra staff rather than just whipping people to do things faster. Although having said that, I found the greatest tool to getting more cases done in a day was just to put more cases on the list. During the pandemic, we went down to 2 cases a day because of all of the enhanced infection control stuff, and it was a little bit difficult to go back up to 3 or more a day, and people were resistant, and we still managed to do 2 cases and finish at 3:30, 4 o'clock. We put 3 cases on the list and said, guys, we're doing it, and quite rapidly our efficiency improved so that we were doing 3 cases a day and finishing at the same time as when we were doing 2 cases a day. But don't stop training your registrars just for the sake of being fast. I'm going to talk a little bit about training now. It's something that is close to my heart, has been from VATS days as well. So we have now a fairly established fellowship model. It's a 6-month program. We appoint by a separate interview. It will soon be linked up to the SCTS badged fellowship, so that hasn't been so far because we wanted to retain some control. Books up about a year or 2 in advance. We've had about 8 people through the program so far. Firstly, you do the online modules, which are the same as new consultant starters. You then get a 1-day wet lab in Oxford, which I think has been very valuable. It's often with Joel as the consultant trainer. If your sanity survives that, you come back and start operating. And it's very important that even though you're going to be spending most of your life at the console, that you understand what the bedside guys do. So they spend the first week or 2 helping the bedside, or probably hindering the bedside assist. Our CSRs are very good at doing evening dry lab training to get your general robot handling skills better. We have simulation available, although only after 4 o'clock when the robot's not being used. And then they move on to console training, which is obviously the meat of it. They get 2 days a week with the same consultant trainer. We have broadly speaking, I did write a modular training program, but it's mostly the common sense apprentice model of training as you start and you progress according to aptitude, case selection, and consultant trainer general mood. Fellowship outcomes, well, there are 2 or 3 of them in the room at the moment, and they're still smiling, so that's the main thing. We've had, I think, 8 graduates so far from a number of countries. Typical case experience is somewhere between 35 and 60 anatomic resections as first operator each, although they'll be involved in up to 140, 150 cases, so 6 cases a week typically, maybe more. The important point is we feel that our graduates it's only a 6-month program, so it's not long. Our graduates are at a point where they are basically ready to take up independent practice. Probably far more so than a consultant who's been through the intuitive training program. These guys basically get a perma-proctor next to them for 6 months, week in, week out. Most of our robotic graduates have gone on to consultant appointment within a year with access to robotics themselves, and we are now just starting a program of alumni group events to build robotic networks, to provide ongoing training, and to have dinner. Why should you run a training program? Well, I shouldn't need to tell you this, but Firstly, you get excellent trainees. We've had consistently fantastic trainees running through our hospital really for the last 5 years, almost consistent, I should say. And a lot of that is the robot attracting good trainees. You should normalize robotic surgery, that we need to move away from robotic surgery from being some kind of fancy trick that a couple of you do and everyone stands in the corner and claps. This is just normal surgery now. This is just how we should be doing normal surgery and how we should be training. I think there's a need to offset the training cost that I mentioned before.